هو الانترفيس والسنه اللي فاتت.
نقدر نبدأ خلاص أستاذ حكمت؟
يا دكتور تمام كده.
اوكي. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. يعني first of all I'd like to welcome you today inshallah. I think this is your last implementation phase session which was workplace based assessment. I think this is the last one, and I hope you enjoyed يعني with us the previous sessions, and hope inshallah today and the next week بإذن الله with the workplace based assessment you يعني make the maximum benefit from this session إن شاء الله يعني either in your clinical situations and I'll try إن شاء الله يعني as it is my passion to introduce some of the strategies or some of the tools of using also AI in workplace based assessment. Let's start inshallah. We will try to make this session يعني interactive as much as possible, but to be interactive it will be only with you and your participation. So let's go first to Menti.com or either to go to Menti.com and write this code which is 544170032, or just scan this QR code which will go with you directly to the Menti to start to answer the questions of our first activity. So you are ready inshallah. And please يعني feel free to ask in the chat anytime, and I follow the chat and بإذن الله will answer any queries as much as possible. Okay.
Doctor, please the code again.
حاضر.
I'm sorry, I need the code.
No problem. Either the QR or this 544170032. I hope والله مس حكمت if you write it on the chat يبقى يعني جزاك الله كل خير. Okay. Let's go to ما شاء الله. Okay. Okay. Present. Okay, ما شاء الله. This is some of these answers of our previous session. So let's go to the expectation, which I think start from learning effective strategies to learn effective and efficient methods of workplace-based assessment, which can be implemented easily. How to do assessment. This is the expectation, by the way. This is the first question. To be good and fair clinical supervisor, good inshallah. Clinical based assessment, lab based assessment, and inshallah we are mainly today about the clinical. To learn sample and quick techniques for formative assessment which are based in real life. MashaAllah, this is a good because most of the workplace based assessment are strategies for formative assessment. I hope I could understand how to implement and assess inshallah types of workplace based assessment. Best and fair assessment يعني best is questionable because I think we can't يعني make it is not the best, but it is about it is related to the appropriate method of assessment that valid and reliable. So it could be by this way maybe the best. I'm not sure. Principle of clinical assessment, yes. Feedback skills inshallah next week. Learning new techniques for clinical based assessment inshallah. Okay. I think we still have some two no good assessment method inshallah, hopefully بإذن الله. Okay, so let's go to the next questions and feel free to write on the chat if you mashallah already you see the I think you see the this. So the question is, what is this pyramid? And I think, mashallah, most of you write it is Miller. Yes. خلاص, okay. Once you write Miller, so you are familiar, but only one who write Miller. But I think all of you familiar with the Miller pyramid. Okay. Yes, it is a Miller pyramid, and يعني Miller, it is the one of the most important pyramid related to assessment, because it guides us in assessment for all. Let's you answer, inshallah. I'm not to answer. Okay, so Miller is 4 levels. The first one, which is for no. The second one is for know-how. The third or for shows, and the last but not least is the for what? For does, which is for today. Okay, so to assess the first level, we have case-based questions, cases, written exam. Can you elaborate more about the tools or the types of know-how? شكرا دكتورة Swamithri. Yes, I hope I pronounce it right. Know-how, show, how. But we have the fourth level. The fourth level, which is does. And did you know that we have another level, which is the fifth, which is what? Anyone knows the fifth level in the modified pyramid, which is? Okay, we have MCQ here, but please write the fifth if you know it. Short essay or multiple choice, MCQ, written exam, okay. So all of these are for the no level, the first level or the basic level of knowledge or recall. But by the way, still my questions about the modified Miller pyramid. The last or the modified one includes the what is, which is related to identity or professionalism. It is the highest one, and I think you will agree with me that the last is the most difficult to be evaluated or assessed, because it is related to professionalism and professional and attitude mainly, and they need more than one tool for assist. Matching activities, that's okay. Okay, let's go to the second level, which is know-how. So what are the assessment tools used for the know-how? We have cases or case scenario. Problem-based learning can be used for both teaching and assessment for assessing high level or high cognitive level. Okay, what else to assess the second or the level 2 of Miller pyramid? Simulation. No, I don't agree that simulation is for the second. Who can answer simulation is for which level? I need يعني to be interactive. Simulation is for which level? I am sure that all of you know. Yes, thank you for shows how. So simulation is for the third level, for show how. Okay, and the OSCE also for the third level, the show how. So OSCE, so you answered the third level. OSCE and the simulation is for the shows how. We have the short answer questions, okay, but we also use the short and the MCQ for the first level. So what is the difference between, mashallah, what is the difference between the short answer questions which used in the first level and that which is used in the second level? Feel free also to open the mic and answer, no problem. Level 5 evaluation. Dr. Stian, I don't know what you mean by level 5 evaluation. Okay, show level. Structured questions, yes. Long, please, let's stop here, because I noticed there is certain confusion between, because you put here mini clinical exam. Mini clinical exam is for which level? Because it is today, mini CX. Wait, please wait. Let us restructure what we wrote. So mini clinical exam, from its name, it is the clinical exam, but a mini one, which can assess which level. Yeah, please feel free, please to
Assess the show how or the action or the practical.
دكتورة مروة mini CX, it is also not for the show how, it is for does level. دكتورة نون, thank you دكتورة نون. It is for the does level, it is the fourth level, it is one of the workplace based assessment that we will inshallah tackle it today. So دكتورة ياسمين, also mini CX, it is for the does, it is one of the workplace based assessment. Script concordance could be يعني based, if it is in the clinical situation, it could be in the know how. Okay, one word question, it is based also one word questions. I am not برضو again, I'm not familiar with what mean by one word question. It is like the question and its answer is just one word, so it is also could be based on the structure of the question, could be in the level of know or know how. Structured question, long case also. Long case يعني usually currently we don't use the long case, but if it's structured, it could be at a higher level also. OSCE in the show level. Mini CX, as we agree, it is the fourth level, which is the does. Problem solving exercise, yes, it is in the know how. Case-based discussion, it is one of the workplace-based assessment. It is in the higher level, and inshallah we will tackle it today. So let us recap till now. We just cover the know and the know how. Know, it is a basic knowledge that need a questions which measure a low cognitive level, recall. So it include MCQ, include essay, long essay, short note, whatever. In the know how, it could be the same type of questions, but with higher level. So you can use in MCQ, for example, a case-based questions using a vignette, using a scenario. Okay, and now it is we are now in the third level, which is the show how. You mentioned mainly two important tools, which is the simulation and the OSCE for clinical, and for the practical, it will be the OSBI. So this is for the show how level. Okay, let's go to the last but not least level of the pyramid, which is for the does. What are the tools that can be used for the does level? So you can answer, please. And also feel free to open the mic or write on the chat. But please يعني participate. The fourth level, okay. Mini CX, yes, one of them. What else?
We can have workplace-based assessments.
Workplace-based assessment, yes.
DOPS,
Yes, DOPS.
and
Yes.
case-based discussions.
Yeah, yes.
Logbooks, portfolios.
Okay, could be considered as not as a tool, rather
Okay,
than
and
a tool for collecting the evidence about the workplace-based assessment and also case presentation. Sorry.
we can
Okay.
have EPAs and trustable professional activities.
Okay, thank you that you mentioned professional activities. Okay, good, mashallah. Sorry, who write the ACATS? I don't know it. What is this abbreviation? So please, can you clarify about ACATS?
Hi, Prof. Muhammad. This is a acute care assessment tool, something similar to Minikix, but like you are collecting like 5-6 cases in just one assessment.
Okay, good. Thank you, Allah, Dr. Ahmed,
Thank
to
you.
give us an idea about this, because I am not familiar with it. جزاك الله كل خير. شكرا دكتور أحمد.
Thanks so much.
Okay, multi-source feedback, which is a very important tool that we can evaluate by it, even the highest level, which is the identity, because through multi-source feedback we can take a feedback from multi-source, from patient, from you work with them. Flipped classroom, it is a teaching strategy. It is not an assessment strategy. EBA, thank you, and DOPS. كده I think that we are now familiar just with the name of the tool, from the first level to the highest level of pyramid, including knows, how, show, does, and even is. Okay, I think we have something here in the chat. 360, thank you, Dr. Somersi. 360 degree assessment, yes, which is, as you mentioned, it is the multi-source feedback and could be used for the assessment of the higher level, including the does and is level. Okay, mashallah. So this is just a start, yani warming up. Patient outcome audits, Dr. Sierra. Patient outcome audits, I think this could be yes, one of the workplace-based assessment, which is based on like a survey or questionnaire to the patient about the trainee performance. So yes, it could be one of the workplace-based assessment and used for the first level. Thank you, Doctor. Okay. So let's go to our presentation today. Inshallah, we will, is the first outcomes, which alhamdulillah already covered by you, to identify the different types of assessment based on Miller pyramid. Then we will go, inshallah, directly to the workplace-based assessment, the educational principle about it. Then we will discuss what is called the utility formula of assessment, which is not only for the workplace-based assessment, but it is applicable to all types of assessment. Then we have explore ways to use workplace-based assessment as a developmental opportunities or for a formative assessment for giving constructive feedback for our students. Okay. Then we have, inshallah, to cover this objective, we have this is topics, educational concept, utility function or utility formula, strategies for workplace-based assessment using different rating scale and using workplace-based assessment strategies. Inshallah, and hopefully we will, inshallah, in the next maybe more than, inshallah, 1 hour. We have less still, okay, about 90 minutes. So let us start by the learning cycle. For any session, clinical, theoretical, whatever, we need to identify the learning outcomes. Then we start to plan for learning and start our learning and instructional activity. And to close the loop of assessment and to close the loop of learning, we need a constructive feedback assessment. And also we need a student to reflect on her or his own learning. And this is, mashallah, the Miller pyramid that, mashallah, you describe it and describe different tools that can be used to assist its different levels. And notice that from the nose to does, it is like from novice to expert or what is called professional authenticity. And also some of the two levels are mainly related to cognitive and the other two related to the psychomotor and the behavioral domains. Okay, so what is workplace-based assessment? It is simply a multiple observation followed by verbal feedback, but it needs high quality documentation using different workplace-based assessment tools that you just mentioned it. So it is based in certain tools for collecting data about the performance of the trainee, but most important that this performance, it will be in the workplace, in the hospital, in the emergency, as mentioned by Dr. Ahmed, in the clinics, whatever, but it must be in the workplace. What we need from it, it is to judge or to evaluate the competence. Is the student or trainee become competent to do certain skills or certain competences? And it could be used for summative and formative purpose. So simply, it is observation. You are the observer, or that the trainer will be the observer that observe the trainee in different situation and in different workplace-based assessment context. And after observation, he or she gives the student constructive feedback about her or his performance. This is followed by a plan for improvement. A student write her or his reflection. This must be documented. By the end of the day, you need to judge if the student is competent or not. So workplace-based assessment is usually related and linked with what is called competency-based education. Okay, simply, this is the trainer that observe, give feedback, student make self-reflection. This is documented in a portfolio, whatever the type of this portfolio or logbook as mentioned by Dr. Asira, whatever the type of documentation. What is still missed in this slide? The still missed is the background. So who can help me to clarify more about the background of this slide? What is in background? Who can answer? And feel free to answer verbally in the chat, whatever, but answer. What is in the background? Which is medical expert, collaborator, communicator, professional, school.
Competency, Saudi competency.
It's a competence. It is
Saudi
not a
medical
code.
expert. The competence, yes.
Dr. Muaz, mashallah, no, it is a CAM-MED. Yes, it is a competency, but it
Can
is a
med or Saudi?
CAM-MED. Yes. Okay, there is a Saudi med. In Egypt, there is that of the nurse, and there is a CAM-MED.
Nurse.
But these are the goals of a undergraduate, sir.
It is not the goals, it is the competencies that the undergraduate is by the way, in CAN-MED it is mainly for the residency program, but yes, it is not it is the competencies that the student must acquire after the end of the program, of the medicine program. And the aim of workplace-based assessment is to evaluate the student against these competencies. He or she will be competent as regarding these competencies or not by using the workplace-based assessment. So again, in summary, workplace-based assessment, observation, feedback, reflection, documentation, and all of this are related to certain competencies, whatever these competencies. Okay, so let's start by what is competencies. Competencies simply, it is the observable ability of health professional integrating multiple components. It integrates learning outcomes, knowledge, skills, attitude to form one competence. And as it is observable, so it can be measured and assessed to ensure that the student acquire these competencies. So it is simply a combination of certain learning outcomes to form a competencies, and against it must be assessed. So we have knowledge, skills, attitudes. This is the learning outcomes of our program or courses, and collectively they form a one competence. Okay, this is and as they just say, this is the CAM-MED, which is related to the Royal College of Physicians in Canada, and I think it was the first, for my knowledge, it is the most known competencies in the world, and many of the framework or other competence framework was derived from that of CAM-MED, like Saudi Med, and I think like that of the nurse in Egypt. Most of them are similar, by the way. So for example, here in Egypt, you have the 6 competences area: the graduate as a healthcare provider, health promoter, professional, scholar and scientist, member of health team, and a lifelong learner. And in Saudi Arabia, we have the Saudi Med that include the competencies include scientific approach to practice, patient care, research scholarship, professionalism, communication, and community-oriented practice. I think one of you, maybe I think Dr. Asira, mentioned what is called entrustable professional activity, or EPA. We mentioned that competencies is a combination of learning outcomes to form a one competence. While entrusted professional activities, it's a combination of 2 or more than competencies to form what is called EPA. EBE, it is a unit of professional practice or task. For example, that the trainee in the surgery rotation should master as a resident, should do appendectomy. So appendectomy could be one of the EBE in surgery rotation. To master appendectomy, he must or she must have the two communication skills and also clinical skills and also some managerial competencies or skills. So it is a combination of certain competencies. By the end, it could be entrusted to perform this task unsupervised, and its name comes from this. The student or trainee can perform this task or unit of professional practice unsupervised once he attains sufficient specific competencies. Not only one competence, more than one competence. Like this, gather a history and perform a physical examination. So it is not only one competence, it is two competences. So simply this is like this image. We have, for example, this is also in CAMMET. We have a combination, so EBE3 in certain program needs the doctor to have to perform it, to have all these competence. So this is the EBEs, and I think in Egypt now the new program 5+2 include in the internship certain EBEs that cover different rotation. Okay, so till now I think we are okay. We start by Miller pyramid, then with the competencies and what we mean by competence, then interested professional activity. But just to recap what is related to workplace-based assessment in the assessment in general. Workplace assessment could be formative or summative. But what is the difference? And you can answer this. What is the difference between formative? I think, mashallah, you are at the end of your, I think, second year. So I think you, mashallah, know that everything about assessment more than me. So what is the difference between formative and summative assessment?
Formative is the assessment for learning, while summative is the assessment of learning. Right?
MashaAllah. Yes, يبقى formative is for learning and summative of learning. What is else? What is the name?
In formative assessment, we give feedback during the assessment for
Yes.
improvement. And in summative, it is at the end of the exam or year or period.
Thank you, Dr. يبقى formative, it is F for F. Formative, it is for giving feedback. But summative, it is by the end, and there is no any room for improvement. The year is ended, and it is the time to judge if the student will pass or will stay with us. So thank you, as you mentioned, Dr. Yasmin, Dr. Asira. It is assessment for learning. It is a formative, while summative is assessment of learning. Formative is to improve learning, while summative is to measure competence or learning outcomes. Formative is ongoing, while summative is the end of course, and formative is to learn through feedback, while summative is for grading. And this is a nice metaphor for them. Informative, when the chef tests the soup, it is formative. You have still an area to add some salt, to improve the recipe. While in summative, when the guest tests the soup, it is a summative, so there is no way for improving the recipe. Okay, what we need from the workplace-based assessment to be like this. We have a big circle for formative assessment and just a small one for the summative. By the end of the course or the training, the student will be, or the trainee will be confident because he or she was assessed. Sorry? Okay, because he or she was assessed many times using the formative assessment, and this is one of the most important idea or concept behind the workplace-based assessment. Okay, thank you, Dr. Satyam. Formative assessment, faceless, friendly, feedback, feed forward, flexibility, fast, mashallah. All RF. Thank you, wallahi, mashallah. I know only one of from them, which formative is for feedback. But we have, mashallah, more than F. So thank you. It's a good code. Thank you, mashallah. Good. So to close the gap, using especially using the formative or using the workplace-based assessment, student work, it will be subjected to many formative workplace-based assessment, and he or she will be given a constructive feedback. He will respond using reflection and writing, and it will be good if this feedback is multi-source from one more than three. This is the introduction. Let's go to another important concept, which is called utility function, and I think all of you know it, which is the utility function. U, which is the utility, R, which is reliability, V, validity, E, educational impact, A, acceptability, and C, the cost. And by the way, it is not a mathematical formula, so we can't say that R equal 0.5 and V1 and E by the end we have a utility certain figure. No, it is not like this. But the most important is this: if we fail in one of these elements, so the utility will be 0. So all of them are equal in their importance for assessment. And it is not only for workplace-based assessment, but for all other types of assessment, we need to consider this utility formula by all its aspects and to avoid any threats to it that may affect the overall assessment process. So in fast way, validity, it is how well assessment measure what it is assessment. And when we are speaking about validity, we are speaking mainly about blueprint. Validity equals the presence of mainly the blueprint. Also, we have reliability, which is the twin of validity, which is the reproducibility or the consistency of the assessment. And the good news in reliability is that it could be measured, and we have more than formula to measure it. While validity, it is difficult to be measured because it is mainly a judgmental to judged or evaluated by experts. We have another items element like educational impact. The assessment must have a big or a great impact on the student. So it is in selecting which outcomes or competence to be assessed. And I think also you all familiar with the assessment drives learning. So to have an assessment that drives learning, you need to measure an important learning outcomes and the competence, not just trivial one. Also the visibility, and we mean here by visibility that we need, if we want to apply workplace-based assessment, it must be visible for us that we have the resources, and I mean by resources here, human resources, physical resources, the training of a student, training of the trainer themselves, and the cost effectiveness. And also I mean here by cost effectiveness, it is not only money, it is the time, the effort of you on developing and implementing an assessment. The last but not least is related to acceptability. The assessment must be acceptable to all stakeholders, and this is mainly during the process of developing or designing the assessment without any flaws in it. Like I think, mashallah, you trained on writing the MSQ, avoiding any flaws in writing it, avoiding even any flaws in the exam paper if it is written exam for example, and by the end it will be accepted by the student, faculty member, administration, all of the parties or stakeholders for the assessment. And for each one, we have some measures to improve or enhance this element of utility function. For example, in reliability, you need assessor training. You need usually one of our professor and one of the director of Famar Institute in India taught us that put the word more before any element of assessment and you will improve reliability. You need more training, more assessor, more methods of assessment, more frequent triangulation, and we mean by triangulation that you use as you assess the student in different situations. The only more that you need to avoid it is more student. By this way, you can improve the reliability. For regarding validity, we mentioned that validity is that mainly blueprint and the other items that related to reliability also can improve it. Acceptability, most of these elements can be improved by training, by awareness, by feedback, by writing reflection. So this is for each of these items of utility formula, you have a strategies to improve it and to keep it without any effect that may affect by the end the assessment process. And again, the utility function, it is not only for the workplace, it's for written assessment, for online assessment. Whatever any types of assessment, you need to consider different element of utility formula and to keep it and avoid any threats that may affect it. So you need to never to neglect any items of the utility form. Okay, let's go to our main scope today, which is the strategies for workplace-based assessment. Again, that we have a cardinal component of workplace-based assessment, as you mentioned, direct observation. It should conducted in workplace and provision of feedback. We mentioned another two items. Who can help me to remember what else in the workplace-based assessment? Observation in workplace and the feedback. Still, we have to miss the items for it. What are those items for workplace-based assessment, please? Who can answer? Participation, please. Okay, in the chat. We have real life situation. Okay, it is mentioned there. Thank you, Doctora. I will not pronounce because I have a difficulty. Conducted in workplace, it is the real life situation. Like we need more. Many CX, Doctora Dina, is one of the tools, but I mean here, Doctora, what are other elements of the workplace-based assessment in general? We need to observe, and it must be conducted in workplace. And give, yes, mashallah, Dr. Ahmed. And self-reflection is one item. The last but not least, it what?
Longitudinal assessment.
Oh, this is, thank you. This is one of the tools of workplace-based assessment. But I just review with you the main concept of workplace-based assessment. It needs direct observation through the tools like 360 degree, Doctora, and like was mentioned by Doctora Dina, which is mini CX. Okay, and it conducted on workplace and giving feedback. And Dr. Ahmed mentioned reflection. After all of this, it must be what?
Must be documented.
Yes, and I'm waiting for this, Doctor. Yes, thank you, Doctora. Yes, mashallah, Doctora Randa, Doctora Dina, yes, Doctora Marwa, yes, to be documented in portfolio and logbook, whatever documentation online, yes, Doctora Dina, log, mashallah. This is the idea of it, of the workplace-based. Why you are using it? This is because first of it, because it measures the highest level of Miller. Focus in clinical, include formative and could be used for summative or formative, include communication, behavior, professionalism, ethics, attitude, observation in real situation as mentioned by you, giving feedback aligned with assessment within actual work. So for this reason, it is the highest. After it will be as, but is the highest level of assessment is the workplace-based assessment. Okay, but we need to remember and to consider that our trainee should be safer. What we mean by safer is to breed assessment through rotation. It is not only one at the start, one in the mid, and one final. It must be, as we mentioned, frequent assessment. Also, as many assessors as possible, not only one. Feedback as well as a score. and there must be their evidence and the follow-up action plan for improvement, and also reflect on what they do, so that to ensure that we have an effective workplace-based assessment. It should be a safe spread assessment, as many as assessor, feedback and degree, evidence, and reflection. Okay. Okay, let's wait. Sorry, let's take this. You can go to the same Menti, but I'll go to it from here. Okay. Okay. You can answer this question, which is, what are the tools used for clinical or practical assessment? Current. We mentioned that the tools which are in general in the middle pyramid. But my questions now, what are the tools that you are use for you for either for clinical or practical assessment? It is the same code 5441 7032. Okay. OSBI, thank you. So OSBI for practical exam, for biochemistry, for mashallah, OSCE. Okay, what else? OSCE, which you mentioned that it is the show level for clinic. Another OSCE, good. What else? We have in the chat also Viva. Okay, thank you. OSCE and the clinical sheet. EBAs, mashallah. So we have some of you using interested professional activity, and some of you using mini CX. والله mashallah. DOPS case أعتقد CBI case base صح؟ case based discussion بس مش عارف CBI what mean by BI case base. Please either correct it or inform us what is the meaning of CBI. I know CBD, case based discussion. Okay. What else? Okay, DOPS, EBAs, mini CX, OSCE. ماشي. Okay. So we can also categorize the skills or the especially in the clinical too. We have as some aspect related to clinical knowledge and skills. So we have case-based discussion. We have some procedural skills, like, for example, inserting cannula, inserting nasogastric tube, lumbar puncture. So it is all these skills or competencies need DOPS. We have also what is called the direct observation of non-clinical skills for professional behavior. We also have here in clinical skills mini CX, as you mentioned. And for interpersonal skills and judgment, we need 360 appraisal or 360 feedback, multi-source, as you mentioned earlier. So this is mainly the tools. For today, inshallah, we will focus on only 3 of them. The first one, which is mini CX, which can evaluate or assess the following competencies: communication with patient, physical examination, diagnosis, and treatment plan. And the assessor can be educational, clinical supervisor, senior trainee. And we have different settings like clinical, ward, and community. The case-based discussion, which is mainly for judgment and clinical management and reflective practice, also the same assessor are the same. And here we have multiple areas covered by challenging cases. In case-based discussion, the key, it is a challenging cases. If you remember in our clerkship, in the rotation, we go the day before the round, and the senior resident or one of the residents give us a note or a case of certain patient, and in the day of presentation, we present the case in front of our colleague, and it will be a matter of discussion about the diagnosis, how this case was diagnosed, why the case was referred to cardiology or nephrology or whatever. So the key element in the case-based discussion, it must be a challenging cases, multi-referral and more than or complicated or whatever. While the DOPS, it is the direct observation of procedural skills, Here it is mainly it is mainly related to procedure or protocols. But يعني remember that it is only can be used for assessing certain knowledge, as inshallah we will discuss today. Dr. Muhammad, many imaging interpretation exercise. ما شاء الله والله good. يعني this is a specific for specialty in radiology. You have many imaging interpretation exercise. Good. Yeah, this is also new for me. Thank you, Dr. Muhammad. Here it is a setting for the DOPS. It could be in clinic ward and field. Good. Okay. So we have again case-based discussion, consultation observation tools, mini CX, DOPS, multi-source feedback, and I think patient satisfaction questionnaire mentioned by one of you, but with another definition. I think it was patient audit or something like this. So it is called in certain area as a patient satisfaction questionnaire. So these are the main tools that can be used for workplace-based assessment. But today, inshallah, we will focus on case-based discussion, mini CX, and DOPS. Okay. Again, a blueprint is essential for any type of assessment, and even for today, to ensure that we have a representative sample of the learning outcomes or competence in our assessment. And when we are speaking about blueprint, we are speaking about validity. To ensure that our exam or assessment is valid, you must have a well-developed or designed blueprint that includes the weight of the area, the domains, and the section examined in it. And this is by the way, the way or the format of the blueprint of workplace-based assessment is different to some extent with that of the traditional that we usually develop for written assessment. For example, we have here in the dimension clinical skills, clinical judgment, communication skills. This is, and also it have what is called the macro blueprint and the micro blueprint. This is a macro one. Just the domains or competence, clinical skills, clinical judgment, communication, ability to work as an effective member of healthcare, ability to apply aspect of public health relevant to clinical setting, culture competences, and professionalism, and the attention to patient safety. So for each one, you write the method or the tools that be used. For example, for the mini clinical exam can be used for assessment of clinical skills. The DOPS for also for clinical skills. For clinical judgment, you can assess it through two tools. Mini clinical exam, but most important, it's the case-based discussion. And the same for all types of the domain, clinical dimension, and this is the different types of assessment. So you can see here that for professionalism and attention to patient safety, you have the multi-source feedback, for example. So this is called a workplace-based assessment macro blueprint. The macro one, it will be, instead of the clinical dimension, it will be called just the heart examination. It could be chest examination, and even for heart examination, it can be also related to auscultation, percussion, whatever. You can also split the competences to its element, 3 or 4. So by this way, it could be like a micro blueprint. But by the end, you must have your micro. You must have your blueprint. Okay, you remember this, I'm sure, inshallah. Workplace-based assessment start by observation, giving feedback, self-reflection, and collecting data in portfolio, logbook, whatever. And in the background, there is a certain competency framework. But the most essential and important element in the workplace-based assessment for us as a trainer is the first step. You need to be a good observer to handle the workplace-based assessment and to conduct it in the proper way and an effective way to ensure that the student will acquire and evaluate it for acquisition of the all competence. And for this reason, you will be evaluated now if you are a good observer or not. For me, I am not a good observer, by the way, but I'm sure that, inshallah, all of you are good observer. You, inshallah, will watch this video, and during watching it, there will be 21 items that will be changed during the video. Your rule, inshallah, to observe what will be changed and mention it after the watching it. And maybe some of you do this exercise before, but please, but for me, I did it many times, but every time I fail in it. But I hopefully you are not the same case like me. Okay, let's watch the video, and inshallah, waiting for your response about the 21 things that will be changed during the video. Bismillah.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
But I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
But how did you know?
Madam, as any horticulturist will tell you, one does not plant petunias until May is out. Take her away. It's just a matter of observation. The real question is, how observant were you?
Okay, so what are the 21 changes that happened during the video? Okay, mashallah, we have.
That one was the.
Dr. Amal, okay, Dr. Sira also was. Okay, what else? Mashallah, mashallah, Dr. Noon, the bear and the iron man. Good, mashallah. Dr. Amal, mashallah, Dr. Amal, a coat, rug, Dr. Randa. And we have flowers, mashallah, Dr. Sira, and a clock was rotated. Dr. Randa chair, mashallah. Usually, by the way, our colleague, our female colleague are observer, يعني ما شاء الله, good observer rather than ما شاء الله. دكتورة دينا body changed position. Okay, دكتورة ياسمين ما شاء الله, the image on the wall, the flowers, the clock, the rug. ما شاء الله عليك دكتورة. دكتور أحمد يا ما شاء الله, we have one of our colleague clock. Good. دكتورة سيرة, wooden log, yes, in hand was replaced. The coat and the hat. Dr. Ahmed, everyone had something in his hand that was changed. Dr. Ahmed, this is the male answer, that which is a global one. Everyone. Okay, thank you, Doctor. Dr. Ahmed Awad, cap. Dr. Sira, body changed position. The whole body changed, Doctora, is another body. Dr. Randa, the gazelle on the wall black instead of white. Yes, mashallah, Dr. Minna. The butler who was holding on, oh yes, a rolling pin, now it's chandelier, صح كده? Okay. The chair, Dr. Noor, shows piece on the back, changed. The policeman, mashallah. What is in the policeman, Dr. Ahmed, by the way? Okay, his coat, I think. Every time I miss, every time I forget some of them. The last comment here, Dr. Ahmed Samir. Although I have the video, but every time which ya salam, mashallah, Dr. Ahmed, we are mashallah together, the same me. Okay, let's see what they mentioned.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
But I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
Okay, So I think we catch the we put the idea or concept behind this, that is the observation. And one of my colleagues usually tell me, Muhammad, يعني good doctor must be a good observer, and I try my best to be like this, but alhamdulillah يعني not success. Okay. So in workplace-based assessment, I think we didn't need a break, but if you want a break, just tell me. We can take if for either for prayer to.
Yes, please, for Maghrib praying.
Okay, no problem. So we can take 10, but this 10 minutes, Doctor, inshallah, will be added to the end, so we can finish يعني 10 or quarter hour يعني instead of 9 in Egypt and Saudi Arabia time. Okay? So we can take, okay. خلاص اوكي دكتور باسم اوكي so ان شاء الله let us ان شاء الله باذن الله restart after 10 minutes ان شاء الله. Okay. Thank you, and please if you have any question just wrote it on the chat and inshallah I'll answer it once. Okay. So in workplace-based assessment, the start it will be by defining the practice expectation for the trainee. This could be through certain EPAs or milestones that the student can move from certain level to another level, or pass the rotation or the mid rotation or whatever. But what we need to clear learning direction and explicit teaching assessment goals. So this is the first step. Then this big circle or larger circle is related to the workplace-based assessment, as we agree. Multiple observation, verbal feedback, quality documentation, using the 3 tools of today, which are the Mini-CX, DOPS, and case-based discussion, will be documented in portfolio. Then the decision could be through a committee, whatever the name of the evaluator, to give the decision. The student will proceed to the next level or next milestone, or he or she need remediation, or even to repeat the rotation till it will become competence. The most essential aspect of competency-based education, which we are using workplace-based assessment for it is there is no, as we usually do, it is like a bus, the student gets a mark, it will pass. No, it is related to if he or she will be competent, it will be proceed. It is not related to the time. It is not, and this is the problem and the challenge on implementing it in a wide scale, especially for the undergraduate, which is related to semester-based and rotation-based or whatever. But in postgraduate, it can be applied because the trainee will stay in the same rotation till it will be competent, or he or she will be entrusted to do certain EBAs without supervision. Okay, so we have workplace-based assessment like Mini-CX and like DOPS and like case-based discussion. So this is the strategy. But we need to have an objective assessment. We need another tools that you can use it through the assessment process. This another tool could be a checklist or rating scale or rubric. If I ask you, which is the best to be used for valid, reliable, objective, all the element of utility function. So you have three to select between them. The checklist, I mean here the best. The checklist, rating scale, and the rubric. Which is the best to use? Feel free to answer. Sorry? Sorry, Doctora, I can't hear you. Checklist. Okay. Checklist, which is just yes or no. We agree about this. Okay. And Doctora Menna, Dr. Ahmed, rubric. Okay. And Doctora Menna, rubric. Dr. Yasmin, rubric. Okay. Rubric, I think all of you familiar with the rubric, which is include the, like a table, includes the category. And for each category, there may be 4 or 5 levels, and each level is well defined. For example, for presentation skills, we have the content. So the content, the student could be excellent, very good, fair, whatever. And for each one, there is a definition for it. Okay, so rubric and checklist. What about rating scale? Rating scales that include just level 1, 2, 3, or good, very good, and acceptable, for example. Okay, so this is about the best that can give us most valid and reliable result. But if I ask you about which one of them will be the most practical or feasible to do it frequent and to do every day, especially with large number of students. A checklist. Okay, Dr. Adine. Who else? Okay. Feasibility and format will be a checklist. Okay. Checklist is the easier. We are not speaking to Dr. Abir about tools, but about how to use another tool for the judgment. Checklist. Okay, verbal feedback, Dr. No. Oh, but verbal feedback is extra, but it is not the main checklist, which is just yes or no. Yani, so for example, we can say that physical examination done, just a check. For heart auscultation, just done or not done, yes or no. This is what I hope that you familiar with the checklist. Just yes or no. Yes, okay. So if we just write yes or no, communication skills, yes or no. Then we have, for example, physical examination, yes or no. So it will be okay. It will be easy. But I agree with Dr. Bassem, it will not be okay, to be honest. So let's go to this exercise together about what is called a scoring rating scale. Here, and unfortunately, no one of you mentions the rating scale, which is the in between the checklist and the rubric. Yes, دكتورة إيمان, هو it is easy with large number of students, but even what we need to not to compromise, but we need to make something which is in the mid, not just yes or no, or a detailed one which may be exhausting to us to follow it and use it in a daily use. So, to be honest, and not me, from the expert in medical education and the clinical assessment, it is the rating scale like this. And even in rating scales, we have two types. One which is called traditional rating scales that will evaluate the student for each component of the competence like this. Start from consistently below expectation, sometimes below expectation, meets expectation, sometimes above expectation, consistently above expectation. So it is, I think, it is better than to mention that it is just consistently below expectation and consistently above, or yes or no. I think is, but again, what is your opinion about this rating scale? Is this working, or we need something? Yes, Dr. Bassem. Okay. Dr. Ahmed, I think most of us are familiar, so familiar with the checklist. List maybe rubric is the best. I agree, والله, Dr. Ahmed, with you that the rubric is the best, but we need in the workplace-based assessment to be used every day and many times with each trainee. Could be objective, work for large group, doesn't work because it can be different. Good, okay, better than the checklist or so, okay, good. So I think it is this traditional one is better than the checklist. It is not like the rubric, but even it can be improved. So the Royal College of Physicians in Canada develop what is called the O score, which start by I am in the clinical setting and I need to evaluate or assess a student the trainee regarding certain skills. So I use this O score, which start by I had to do that means that the trainee can't do it without anything of the component of the skill. Then if she or he might be much better, I had to talk them through that, like I can need to go step by step with it. Then I had to direct them from time to time. He is much better. Then I need to be available just in case, just in case if he need certain guidance. The highest level, I didn't need to be there. So what is your opinion about using this, what's called O score? Is this much than the traditional one or the same? And why? I think, Dr. Bassem, it is more effective. But why it is more effective? Yes, Dr. Asira, it is better. It is better because it is like we can do in the real life. If I have my student with me or trainee with me, then what I'll do, I just direct them from time to time. So clearly, I give him 3. I need to be available in just in case that he do most of the work without any observation, or I didn't need to be there. So it is relevant. Thank you, Doctor. It is exactly tell us where to act. Yes, Dr. Adina, it is about the weight of the role of the tutor. Yes, show more objectively, Dr. Best. Yes. So I think this is much better than the traditional one and much better than the checklist. And it is not like the rubric. Rubric is, I think, my humble opinion, it can be exhausting to us. So this is the Canadian develop for certain or many competences. One like this, for example, I think is related to ENT. I think this operating room evaluation, for example, and one for and this is the details of it. I had to do require complete hands-on guidance, didn't do or wasn't given the opportunity to do. I had to talk them through, able to perform a task but require constant direction. I had to prompt them from time to time, which means demonstrate some independence but requires intermittent direction. I need to be in the room just in case, independence but unaware of risk and still requires supervision. The last one, I didn't need to be there, complete independence, understand the risk and perform safely, practice ready. One of the advantage of this model or this score, that if the student asks you why you gave me 4 or 3 or 2, you can tell him because you can able to perform the task, but as you see, you required a constant direction from me. طب why you give me 4 for this reason? So using this score, I think it much better than using the traditional one because it's based on the performance of a student. It is highly reliable, excellent evidence for validity. Don't need rating point reading the instruction. Resident accepts low mark and even will acknowledge the high mark. Staff use whole scale. Resident not increase daily feedback when these tools used. This is from the evidence based when they use it. Okay. Why is this scale seems to work, including the traditional? Because we can use the traditional, but I show you one of the recent or the advanced one of the scale. Is because of this. It is related to the score, related to the entrustment. When you can give the car keys to your son or daughter and without any fear that la qaddar Allah, she or he may make accident. When you entrusted him or her that, inshallah, she is qualified to drive anywhere, anyhow, whatever. So it is about entrustment. You gave the student or trainee the key, which is the patient, to deal with him at any time. And even if you remember when we were resident, the senior resident or the specialist or consultant with us, go to the accommodation or go to home and leaving us and entrusted that inshallah the shift will be safe with us. It is about entrustment, about which is the main key or idea about EBAs. Okay, let's go now inshallah back to the last part of our session, which is about using workplace-based assessment strategies, which inshallah will be like hands-on. Inshallah, we will cover as much as we can the mini CX, the DOPS, and the case-based discussion. Start by mini CX. Mini CX, which is mini clinical exam. It is one of the tools that can be used or strategies that can be used for assessment for learning, mainly for formative, but also it can be used for the summatives, which is consultations or patient-trainee interaction observed by the trainer or assessor using a rating scales, whatever it is, the traditional or the O scores, and cover range of clinical problem, clinical skills, and evaluate the trainee clinical and communication skills, judgmental and synthesis. Focus in history taking, examination, diagnosis, explanation, consent, and management. And as we mentioned, it could be used for giving feedback, encourage reflective approach, help the trainee to build evidence, because in all workplace-based assessment, the trainee, there is no maximum or appropriate numbers of the workplace-based assessment per rotation. It is again about competence. So sometimes the trainee or resident come to you, or the intern come to you and ask you, please, doctor, can you make mini CX for this case or DOPS for this case to improve her or his skills and competence. Can cover history taking, physical examination, diagnostic skills, management, clinical judgment, communication, and listening skills, organization, time management. Many skills, which is clinical skills, but it is a mini one. Okay. The trainee select patient consultation, assessor observe, trainee present finding, assessor or trainee discuss the scenario and the consultation using the form, assessor provide feedback, assessor record the feedback, upload it in the online platform if any. Then the logbook is completed. This may take about from 10 to 15 minutes. Based on the trainee level, in the early case, in the early years, for example, internship or R1, it could be in clinic, breaking bad news, ward, ambulatory emergency, dealing with patient-related complaint. When in R2, R3, clinic, guiding a junior clinic, breaking bad news, but in unexpected setting, leading a ward, again, A and E, but severely ill, dealing with dying patient. The final stage are 5 or specialist, leading a clinic, guiding a junior in clinic, breaking bad news, leading a ward route, ward emergency, emergency interviews, patient relative, dealing with dying patient, conflict resolution. So this is different level of many clinical exam. As we agree that we need to consider and not to compromise the utility formula. So to improve the validity and reliability of workplace-based assessment, mainly Mini-CX, we need assessor training like today, linking it to learning outcomes or competencies or EBAs. It is the blueprint. Use it for formative, use frequently, use different setting, to make triangulation of data about the trainee, increase complexity with increase the level and the performance of student or trainee competencies, giving feedback and trainee reflection. There is like a role distribution about the trainee and the assessor and both. For example, for the trainee, it need to arrange the case of Mini-CX, arrange to have form, reflect on the case. Assessor, observe and observe and observe, receive training, and also he or she must have expertise in the case. Both together, like a partner, ensure the patient has consented to the observation, make suitable time, agree the focus of assessment. And the same during the Mini-CX, trainee conduct a consultation, trainer observe, discuss the encounter, summarize the feedback, expand the areas that need improvement, include suggestion, and ensure the form, feedback, and the area are observed. What will be done after the Mini-CX? Trainee upload the feedback on the portfolio, especially if it's online platform, reflect, and follow-up action plan. The trainer validates the assessment in good time, review it, and try to validate it by comparing it to other performance, either the previous one or other strategies. If necessary, follow-up action plan. If there is any need, or as we mentioned, or says that trainee in difficulty, it may need to intervene or refer it to the, for example, program director. We have different based on specialty. In medicine, history, physical examination, surgery, post-operative evaluation. OB-GYN, you have abdominal examination of pregnant patient. Pediatric, complete oral presentation of a case, for example. Neurology, history examination, complete neurological examination. In radiology, I think is what mentioned by, I think, Dr. Muhammad, we have another tools in radiology can be used instead of Mini-CX, family medicine, urgent care evaluation in ambulatory setting. And this is one of the tools that was developed by Norsini, and inshallah I will share with you by the end one of the AMI guide, which was published in 27, which is about workplace-based assessment. This is like the reference guide for us for workplace-based assessment. Here it is, and you can use this form or modify it based on the context and situation. Include here the doctor name, GMC number, clinical setting, whatever it is, inpatient, AE, acute admission, then clinical problem in which category, the student level, then for many clinical exam, this is the item of the rating scale. This is, by the way, the traditional one. History taking, physical examination skills, communication skills, clinical judgment, professionalism, organization efficiency, overall clinical care. And you have here, I think, unnoticed. Sometimes one of these components can't be judged, so you can check this. Okay? And you have here, which is unable to comment, you see. You need also to write your written feedback, anything especially good, and suggestion for development. Agreed action between you and the trainee will be written in the form. So it is most important to document the many clinical exam in this form, because this is like a progress. The student can compare his or her performance in this time with the next one, and it will be like the evidence for the judgment about trainee competences, that he or she will pass the rotation or will need remediation or even to repeat it. And also most important to write the level, because the level of a student or trainee will and his or her performance will be different based on her level in the rotation. Okay. What we have now, inshallah, it is like a group exercise for the whole group. What we will do, inshallah, you will watch a video for mini clinical exam, and after it, you will evaluate the trainee. He is a 5th year medical student. You will evaluate him using the traditional scales based on this criteria: history taking, physical examination, communication skills, clinical judgment, professionalism, organization efficiency, overall clinical care. Okay, so let's go to and this is the scales: rarely meet expectation, inconsistently meet expectation, sometimes exceed expectation, consistently exceed expectation. So this is the video, inshallah. Let's watch it together and start the evaluation of this student. Bismillah.
So in order to give you some background about what the purpose of this exercise is, do you have any questions just right off the bat?
So it's going to be a post-operative patient.
Exactly.
And I'm essentially getting like handoff from you.
Yep,
Okay.
that's exactly right. So imagine that you're the intern coming in the morning. I'm the night person. I'm going to tell you what you need to know about this patient. You're going to take some time, and then you'll go see them, and then you're going to come to rounds and tell your chief everything that I need to know about this patient in order. A 37-year-old female whose medical history is most significant for ulcerative colitis, refractory to medical treatment. She was diagnosed with hypercoagulability, inclusive of cerebral venous thrombosis, a DVT, and a PE in June of 2014, and has been anticoagulated. And then due to the medical refractoriness of her condition, ultimately decided to undergo surgery. And now today, she is post-op day 1 after an ileostomy closure. So your goal is really to focus on that surgical episode of yesterday.
Okay.
There were no complications during the surgery. It was very straightforward. She had no acute events overnight. And then you're going to pick up with her this morning.
How are you? Hi, my name is Yuri. I'm a student with surgery. I'm just going to check up on you, okay? Sure. Is that okay? Just trying to make sure you're doing okay. So how did last night go for you?
Good. It was up a lot in the night, but dozed some this morning, so I'm doing all right.
Okay.
Yeah.
How's your pain level?
It's manageable. Right now it's about a 3, I guess.
3?
So, yeah.
Okay, so manageable.
Yeah.
Is the pain medication they were giving you controlling that? Do you think it's working for you, or?
Yeah, I think so. They changed up the oxycodone, and I think that helped.
Okay, that's helping.
So, yeah.
Great. So, and any episodes of nausea, vomiting last night?
None.
Okay.
Yeah.
Any diarrhea?
No. I've evacuated waste twice, and that's been fine. But that was after I ate today.
Okay. And you told me you're walking around fine. Is that?
Yeah. I've been doing laps around the hallway.
Okay. That's going okay for you?
That's going fine.
Okay.
Yeah.
Any dizziness when you stand up, or?
No, but the incision just aches a bit more when I sit up or
It's a little more
stand.
painful. Okay.
Yeah.
Okay. Any shortness of breath that you're having? Anything?
No. Voice is still a little raspy from the anesthesia.
Okay.
So
But no chest pain, shortness of breath?
no.
Okay.
Yeah.
Very good. Is it okay if I examine you?
Yeah, sure.
Okay. And you're going to the bathroom, you're peeing okay?
Yes.
Okay. And you're drinking?
Yeah.
Okay.
Probably could be drinking more, but doing as much as I
But
can.
it's going down okay?
Yes, it's going
Okay.
down fine.
I'm just gonna take a look here.
Okay.
Is there any pain there?
Tiny bit over here.
Okay.
That's fine.
It's fine. And the dress, is it soaking through, do you think?
It's soaked through the first night, but this morning it's been fine.
Okay.
Yeah.
Sounds good. Let me just take a quick listen to your lungs here.
Cool.
Just relax and just listen to your heart, okay? Okay, very good. Can you lean forward and take a deep breath for me? Okay, big breath. Great. One more time. Okay. The assessment plan for her. She's post-operative day 1. She's doing well with her pain control. She's not endorsing any symptoms now. So for her, really, we're just going to try to oralize her pain medications, continue to encourage her out of bed. She's ambulating. We're going to advance her diet as tolerated. Discharge home with.
Okay. Now it is the time to assess this 5th year medical student. Okay. Let's go to the same Menti. Let's start step by step. And the code is in front of you. 5441732. The first element or item, which is about history taking. So sometimes exceed expectation, meet expectation, rarely meet expectation, inconsistently meet expectation, consistently exceed expectation. So it is the time you to evaluate, and even feel free to evaluate it in on the chat. Okay, meet expectation. Okay, good. Sometimes exceed expectation at 1. Okay. Okay. I think we have 8 meet expectations. Who else? Please, if you want to evaluate on the chat, no problem. But please participate. We have meet. Okay. So I think, yeah, alhamdulillah, we are consistent in the judgment or in the evaluation. Okay, let's go to the second one, which is about physical examination. Okay. Meet expectations. Oh, mashallah, we have now a variety. Sometimes exceed expectation, really meets, mashallah. We have if anyone need to comment, please يعني share meet expectation, Dr. Salo and Dr. Sira. Okay, and I think Dr. Muhammad was in the previous one, really. Okay. But yeah, alhamdulillah, برضو also we have meet expectation. Okay, if we add that in the chat, so yeah, the most of you agree about meet expectation, alhamdulillah. Okay. This is the physical examination. What's regarding communication skills? We have sometimes exceed expectations and meet expectation, and in the chat we have Dr. Amira, meet expectation. Dr. Ahmed, he has no, to be more empathic. شكرا Dr. Ahmed. Okay. And here we have mainly sometimes exceed expectation and meet expectation. دكتورة أميرة consistently exceed expectation. Not follow protocol of infection control. Okay. دكتورة سلوى, is this in the communication or can be added in the feedback, which is good observation. Dr. Muhammad.
It can be added in the feedback because he shake hands the patient and he touch the body without wearing gloves, and
What?
he didn't put a distance between. Yani he should be put a distance between the patient and himself.
Okay, good, doctor. Sometimes we have one of the item which is like overall. In this overall, sometimes the student is doing well in most of the element of the items of the examination, but we have like a red flag. Like sometimes this may be sometimes something like this. So sometimes even he pass everything, but we need to mention this and need to mention that this is especially for this, and as mentioned by Dr. Ahmed, for example, no, he will not pass or need to repeat something, for example. Doctor meets expectation. Okay. So also most of you about sometimes exceed expectation. Okay, good. And now we have the clinical judgment. We have meet expectation and consistently meet expectation, sometimes exceed expectations. So what is your opinion? Okay, and on the chat, meet expectation هنا. Okay. The majority is about meets expectations. Okay. Still meet expectation is majority. Meet expectation, Dr. Salwa also. Dr. Sira meet expectation. Dr. Amira meet expectation. Okay, so this is the majority about meet expectation. Okay. And in the for professionalism, we have meet expectation and consistently meet expectation. And what else? Okay, still the majority will also meet expectation. And mashallah, alhamdulillah, we are consistent about our judgment to great extent. Meet expectation, sometimes exceed expectation. Okay. And here we have Dr. Sira meets expectation. Good, mashallah. And also Dr. Amira exceed. ماشي. Okay. And for organization and efficiency, we have meet expectation, and from you also. Rarely meet expectations. Sometimes exceed expectations. And on chat, Dr. Amira meet expectation. Also, the majority is meet expectations. Okay. Meet expectations. Okay. ماشي. And consistently more one. Okay. And on the chat, we have Dr. Sira meet expectation. Okay. This is what I mentioned. Overall clinical care. What about it? Which is like a control one, which collectively and consistently meet expectation. Okay, sometimes exceed. Okay, sometimes exceed. And on chat, we have meet expectation, and consistently meet expectation, consistently meet exceed. Okay, we have here different opinion to some extent. The meet is the majority meets, but we have also on different, and on chat we have Dr. Salwa meet expectation, Dr. Amal meet expectation. Okay. Dr. Sira meets expectation. Good, ماشي. يعني okay برضه the majority meet expectation. It is about anything especially good. Communication skills, communication. Okay, what else is especially good for this student? In addition to the communication and the patient care, good. What else here in the chat? Okay, professionalism. شكرا دكتور أحمد. Nothing good rather than communication and the patient care professional. Okay, good. Communication skills, professionalism. That's okay. يعني most of you agree about communication skills and Dr. Salwa also professionalism. Okay, I think I agree with you. Interaction, communication. All is about communication and professionalism. Okay, good. And now, what need healthcare improvement? This is about, I think, about suggestion for development, clinical examination, differential diagnosis, investigation. What else need to improve in this student? On the chat, دكتورة أحمد. Okay, chevron و redemonstration. Maybe Dr. Salwa, due to the reason you mentioned it, I think this or what? Okay.
Yes, doctor. Yes, he need to practice more.
Okay, good. Okay, more practice. شكرا دكتور. دكتورة Asira, communication should be more. Okay. And here, I think also we mentioned that infection control precaution, from clinical knowledge. Thank you. I think this is Dr. Ahmed. History taking skills. Okay, okay. More clear. By the end, you mentioned here something that the student need or that we need to consider in this time. When he will repeat another mini clinic reflection and feedback, when he will repeat this mini clinical exam, he will consider it, and you as a trainer will consider it in evaluation with the aim for improvement. Okay. Thank you. So this is mini clinical exam, a real example, and mashallah, you practice it well, and alhamdulillah, to great extent, there is a consistent evaluation between you. We have another example for many clinical exam, but I leave it to you, inshallah, to review it, to go to another strategy, which is the DOPS, or direct observation of procedure skills. From it is mainly related to procedure. Okay, so to assess procedure skills, essential for clinical care. Again, you will select the most important technical skills, like, for example, if internship or in family medicine rotation, application of simple dressing, breast examination, cervical cytology, female genital examination, male genital prostate examination, rectal examination, testing blood glucose, aspiration of effusion, cauterization, cryotherapy, curettage shave excision of skin lesion, incision and drainage of abscess, joint and peri-articular injection, hormone replacement implants, proctoscopy, suturing of skin wound, taking skin surface specimen for mycology. So this could be considered this is, by the way, mainly in R1 family medicine rotation, but it could be also in the for internship. And this is also in the same EMI guide of Norsini. He developed this rating scale for different DOPS. But sometimes you need to tailor a specific one for a specific task or skills. So he has here demonstrate understanding of indication and relevant anatomy technique of procedure. So this is like a knowledge. This is not a skill, a procedure skills. Obtain informed consent, which is related to attitude or behavior. Demonstrate appropriate preparation procedure, appropriate analgesia or safe sedation, technical ability, aseptic technique, seeks help where appropriate, post-procedure management, communication skills, consideration of patient professionalism, and overall ability to perform procedure. And also we have area for written feedback. So this is the skill that will be used. We have another exercise like the first one, and I'm sorry that we will also use the rating, the traditional one, which start from rarely meets expectation till consistently exceed expectation. But we have here a procedure which is lumbar puncture. So inshallah the same, we will watch the video, and after this we will evaluate the student who is, I think, maybe R1 or R2 family medicine physician. So Bismillah.
I think a lumbar puncture would be appropriate at this stage.
Yeah, okay. Can you outline the indications and contraindications?
Okay, so the indications would be checking for infection, as in this case, so looking for a high white cell count, low sugar, raised protein. The other indications that you could check for is blood to exclude a subarachnoid hemorrhage, or to check for pressure in case conditions like benign intracranial hypertension.
And what about contraindications?
So I certainly wouldn't do a lumbar puncture if there was a clear sign of increased intracranial pressure, obstructive hydrocephalus, and other indications, contraindications would be coagulopathy and local infection. Shannon, we need to do a procedure to check the fluid around your brain for infection. It's called a lumbar puncture. Are you familiar with that?
Well, I've heard of it, but I don't know what it is.
Okay, so we want to take a sample of fluid from around your spinal cord. The fluid around your brain goes all the way down to your spine, and the best place to get it is at the base of your spine, in your back, between your hips.
So like an epidural.
Yeah, like an epidural, but it's using a smaller needle, and we go in deeper. An epidural doesn't go into the spinal fluid.
Okay.
So it's important for you to know that with every procedure, there's a risk of complications. So some people can get persistent headaches, which may need further treatment in the future. In rare cases, people can have damage to the nerves as well as infection.
And how often does that happen?
Well, the headaches, I guess, are about 5% or less than that. The infection and damage to nerves is far rarer. I've never seen it myself personally. The less than 1%.
Okay. Well, how many times have you done this?
I've done the procedure twice, but that's why I have Bill here. He's going to supervise me through the whole procedure.
Okay, seems okay then.
Okay, great. So if you have any questions, please let me know. We can go through those. Otherwise, I have a consent form here. If you wouldn't mind signing this, essentially because we're doing an invasive procedure, it's a consent form to say that you're happy for me to proceed with the procedure with Bill supervising. Would that be okay?
Okay.
Just get you the sign.
Okay.
Repeat. We'll get started. Okay, Shannon, we're going to get going now. So what we'll do is get you to put your head down, curling your chin into your chest and holding onto the pillows there. I'm just going to feel of your back. That's great. I'm just going to be sharp scratching out. This is the local anesthetic. All right. You're going to feel some pushing now. Sliding out. Resting on your back. Good. That's all done.
Sounds.
Yep. So the fluid looks clear, which is good. We'll send that off to the lab for testing, as we mentioned before. And when we have the results back, I'll come back and let you know. If you have any headache or any pain, please let your nurse know. Otherwise, for now, just rest up.
Thank you.
Good on you.
Okay. Before going to the evaluation, Dr. Ola يعني asked a very important question on the chat, which is about can DOPS be performed on a simulator, medical mannequin, or even a virtual environment? Yes, it can be done, Dr. Ola, but it will not be a workplace-based assessment. It will be a simulation which assess the third level of Miller, because the DOPS that we are just discuss it now, it is about a real life assessment in the workplace. So we can use the same, even the same checklist, but it will not be on used to be as a workplace-based assessment, especially here for DOPS. It is not only for the skills; it includes communication skills, consent, pre and post procedure element or skills to be done. So if you do it on mannequin or simulation, it will be for the third level, which is show how. But it can be done like a preparation for the real life DOPS, which is already done, especially for example, in robotic surgery. The trainee can do the robotic surgery many times on the simulator, on the clinical skill center, before it will be done on the real life or in the real patient. So thank you, Dr. Ola, to mention this, because this is an important issue, and to differentiate between the third and fourth level of Miller pyramids. Okay, يعني إن شاء الله إحنا after this we will finish بإذن الله and we'll postpone the case-based discussion to the next time with the feedback and reflection. Okay, just to evaluate this student, and إن شاء الله we will finish not to يعني extend more than the time. Okay, so let's start by the checklist. Okay, sorry, is medical record hearing? We need sorry. Okay, this is the case-based discussion. So okay, the first item in the checklist is about demonstrate understanding of indication, relevant anatomy, and procedure of techniques. So what is your opinion? Please also write on the chat if you want. Okay, meet expectation. Okay. Okay, sometimes exceed expectation, meet expectations. Okay. And we have also in the chat, meet expectation. شكرا دكتورة أماني. Okay. Okay, so we have mainly the majority meets دكتورة إيمان شكرا. Okay, mainly meet expectation and sometimes, okay, good, ما شاء الله. Still we consistent. Then go to and consider the level. He is R1 family medicine rotation. Here we have obtain for informed consent. Sometimes exceed expectations is a previous on Dr. Sira, I think. Okay, meet expectations. Sometimes exceed, consistently exceed expectations. And we have here on the chat exceed. شكرا دكتورة إيمان. Thank you. We have meet expectation, exceed. So يعني الحمد لله also. We still sometimes exceed, we meet, consistently exceed. Good, mashallah. And still we are consistent. This means that we have a good reliability, which is called inter-rater reliability. Good. And here for the demonstrate appropriate preparation pre-procedure. We have meets expectation and consistent meet expectation. Okay. Also, the majority between on the chat we have Dr. Asira meets expectation. Thank you. Meets sometimes exceed. Okay, يعني ماشي. Okay, which is acceptable. And on the chat we have meet expectation. Dr. Iman, Dr. Amira meets expectation. Thank you. And also we have Dr. Amani meets expectation. Thank you, Dr. Amani. MashaAllah, good. Okay. And if you have to write any comments about the performance, feel free to write on the chat. Appropriate analgesic and or safe sedation, consistently meet expectation, and rarely meets expectation. Okay. I think we didn't have surgeon with us, because if we have surgeon or anesthesia, mashallah, they usually they need the best, and their expectation is usually high. So it seems that you have a kind heart, that of basic science, and some of the clinicians like in pediatric who give generous in giving their evaluation. Okay, and for the technical ability. Okay, we have meets expectation, sometimes exceeds. Okay, we have inconsistent meet expectation, and on the chat we have meets and the meets. Amira, thank you. Okay, alhamdulillah, I am happy that we are consistent in evaluation. And for the aseptic technique, rarely meets. Okay, and we have also on the chat meets expectation as year one resident. Thank you, Dr. Amani, that you elaborate more about the expectation in relation to his level. Yes, thank you, Doctor. Rarely and the meet. Okay, good. Okay. And here also for seek help when approach. Sometimes we can write unable to comment. Level of training. Thank you, Dr. Muhammad. Meets expectation. Yes, Dr. Muhammad, about the level of training. Yes. Rarely meet expectation. MashaAllah. And seek help when appropriate. I think here is unable to comment, because I think there was no need for help. I think this is my humble opinion. Okay. Post procedure meet expectations and also meet expectation, and also have on the chat Dr. Amani, thank you, meet expectation, and Dr. Amira meet expectation, thank you. Okay, so have 10 meet expectation. MashaAllah, all agree about the post procedure management. Communication skills. Okay. Meet expectation, Dr. Samarin. Most expectation, meets expectation. Okay, consistently exceed. Alhamdulillah, برضو to some extent near each other. Meets, consistently exceeds. Okay. It seems that you are tired, because the number who are participating is decrease. No problem. Also, we just have maybe 2 or 3 slides. Okay. Consideration of patient and professionalism. What you notice here that in DOPS, it is not only related to procedure skills, but also include some of the professionalism, knowledge, and communication skills. Dr. Asira and Dr. Khoshbo meets expectation. Okay, here we have meet expectation, consideration of patient meets expectation. Okay, meet expectation, Dr. Amira. Okay. And the last one, overall ability to perform, which is again, it's like a control one. That we sometimes in the metrics, for the quality metrics for this types of assessment, we need to correlate between all test item or assessment item and this, the overall ability to perform procedure with other item, and usually there is a good correlation between them. Here we have meet expectation and meet expectation from Dr. Amani and Dr. Somsiri. صح؟ This is correct. Okay. Now it is about the feedback, which anything especially good. Meet expectations, the previous one, دكتورة أميرة ودكتورة سميرين meet expectations. طب الحمد لله. Okay. Anything especially good for this trainee? Okay. Anything especially good? Nothing? Communication technique, self-confidence. What else? But by the way, communication technique and self-confidence, this was from my previous training, not from you. Good technique, okay. Good technique, thank you. Communication and being confident, mashallah, good. You agree with the previous training group. Communication, thank you, Dr. Wissam. Okay, and also we have Dr. Asira, communication and professionalism, reassurance. Okay, mashallah, there is a consensus about this. Dr. Amira, according to his level of training, communication, observation, I am happy that you write this, that it is about the level. Being calm and assuring the patient, thank you, was ready to take help when required, and this is a reassurance to patient know his limitation and be honest with mashallah. والله جزاكم الله كل خير. You are good observer. Communication and professionalism, thank you. Communication strategies, mashallah. Okay, mashallah. والله I am happy to your participation till the last moment, because this is the last moment, which is about something which is good, and mashallah, confidence and good techniques. Thank you, Dr. Amani. Okay. This was the last activity, which for DOPS, and mashallah, you do a great job about the workplace-based assessment for the mini clinical exam and for the DOPS, and inshallah, we will start next week with the case-based discussion, followed by giving constructive feedback and writing the reflection. Thank you, Dr. Asira. MashaAllah, to the last moment, confidence. Okay, wallahi, I am too happy that you are wait for the last moment and participate. شكرا لكم جميعا. Thank you, Dr. Amira. Thank you all for today, and inshallah, I hope you benefit from this session, and inshallah, next week we will continue the journey about workplace-based assessment, starting by case-based discussion. Follow this, inshallah, about feedback, portfolio, reflection, and try, inshallah, to integrate AI in the next session. جزاكم الله كل خير. Thank you. See you. Many thanks, Miss Hikmat. جزاك الله كل خير. As usual, you are with us as a supporter and helper for every one of us. And see you, inshallah, next week. Thank you. السلام عليكم ورحمة الله وبركاته. شكرا لكم جميعا يا جماعة. السلام عليكم.
عليكم السلام ورحمة الله وبركاته. شكرا يا دكتور.
ألف سلامة الله. ألف سلامة. مع السلامة.
مع السلامة.
عندي سؤال، هو احنا هندخل ميتنج تاني ولا ايه اللي هيحصل؟ في حد عنده معلومة؟
اصلا مفيش ميتنج تاني.
امال هي ايه اللي اللينك ده؟
لا، هو كان في ناس خرجت يا دكتور وما كانوش عارفين يدخلوا، فبعت لهم اللينك من الزوم نفسه.
اوكي، طيب معلش ما كنتش
هو نفس الفيديو.
اوكي، طيب انا افتكرت ان في حاجة حصلت. طب هندخل حاجة تانية، عشان كده بقى سألت. تسلمي، ربنا يخليك. شكرا.
لا، العفو يا دكتور.
شكرا، ربنا يجزيك كل خير. معلش احنا تعبينك معانا والله.
لا
ربنا
طبعا،
يجزيكي بينا الجنة.
تسلمي يا دكتور.
يا حبيبتي، مع السلامة.
مع ألف سلامة. عن إذن حضرتك. Good night.